colleagues. Let me introduce my PhD topic and the follow-up work for the 15 months progress report of my PhD topic about treatment possibilities in oro-maxillo-facial rehabilitation. My vision is to have an evidence-based maxillofacial prosthodontics, and for doing this, we have to establish proper scientific output, and here are the first few steps to achieve that. My first project is about face digitizing, because there are many people who develop head and neck cancer every year, and some of them receives a facial defect which is unrepairable surgically, and there's an allocational problem as well, because prosthetic treatment is unfortunately inaccessible for many due to the high cost and the required personnel. But the advances in digital technologies could resolve this issue through a so-called trickle-down effect. So we have to simplify the workflow in order to let more patients receive this kind of treatment. And the first step of this is simplifying the impression taking of the face by replacing the conventional impression taking technique with surface digitizing. So we are in the need of a reliable and quick method for digitizing a face. And we have to validate first the accuracy and the trueness of these digital representation by comparing direct measurements taken on the face with virtual measurements taken on the digitized models of the face. And our null hypothesis is that it should be no difference between the scanning technologies and the facial regions. What is the clinical significance of this? Any dimensional change will result in a ill-fitting prosthetic appliance. However, the threshold of this accuracy is not based on consensus. Some say 2 millimeters is sufficient for the practice. Some say it's even less than 100th of a millimeter is required. We conducted a systematic search in 5 databases, and from the results, I'm only showing you the nasal region from our analysis. And what we can see is that these interlandmark distances are showing the depth and the width and the height of this specific region. What we can see here is a mean difference analysis, and the effect sizes range from minus 0.43 to 0.46 millimeters. However, the confidence intervals are much wider than that, around 1 millimeter. So our conclusion is that there's no systematic error or no systematic skew in the digital representation of the faces. However, the accuracy is not in the clinically acceptable range in either region, and the clinical usability differs substantially. It's still more preferable over traditional impressions due to enhanced patient comfort, but for research, further research should be conducted with people with actual facial deficits, because these articles only measured healthy faces, and we should explore the learning curve of scanner usage. The strength of this review is that this was the first 3-dimensional and regional analysis, and the same methodology was used throughout all the included articles. Therefore, the heterogeneity was pretty low. Unfortunately, not all regions were involved, especially the auricular regions were not involved in the analysis because of data insufficiency, and the involved population, again, mostly consisted of healthy individuals. Currently, this manuscript is under the second round of revision at the Journal of Prosthodontic Research. My second project revolves around the rehabilitation of maxillectomy patients. In these situations, we have 2 paths ahead of us. The first one is the surgical reconstruction. The other one is the prosthetic obturation. The choice between these 2 rehabilitation methods, unfortunately, based on controversial evidence. And the aim of this review is that to summarize all the available information about these 2 options. The first question is that how do these different restorative interventions help in the patient's quality of life? We've compared quality of life scores from different domains and different questionnaires, masticatory indices, speech intelligibility, and the nasality of the speech. And our null hypothesis was that there should be no difference between the interventions. The second question is that how do the basic characteristics of the patient influence the effect of the interventions? So by comparing the quality of life scores to the mean age, the degree of maxillary edentullousness, the defect size, and the received radiotherapeutic dosage, and the null hypothesis is again that there should be no difference between the stratified population. We conducted the systematic search in last October, and at the end we got 9 eligible articles to the meta-analysis. So for the first question, we found that these questionnaires were used commonly in the publications, and we compared the common domains of different questionnaires and the different domains from one questionnaire, and due to time constraints, I'm only showing you this latter one, namely that domain differences measured with the University of Washington Quality of Life questionnaire. What we can see here is a score as the outcome between 0 to 100. 100 is representing a higher number of problems, and there's a slight tendency that is favoring surgical reconstruction, with a great exception of Aladashi et al., because this shows a remarkable statistical significance. However, the baseline differences shows that these can set the obturator group back, because in this randomized control trial, a surgical obturator or a so-called temporary obturator was used and put against to a definitive surgical reconstruction. In the Narita et al. Study, the obturator group, the patients in the obturator group had fewer remaining teeth, which doesn't allow the obturators to properly function. So these differences are heavily confounding the end results. The second question, unfortunately, couldn't be answered because the meta-regression was not feasible, because at least 10 reports should have been included. So this is still yet to be answered, however, not in the form of a meta-analysis. The conclusion is that the data suggests no difference between the two choices of the reconstruction. There's a slight tendency that is favoring surgical reconstruction, but this may not represent the actual truth. And if it's proven to be at the same level of efficacy, the prosthetic rehabilitation is proven to be a much more cost-effective type of rehabilitation. So the implication for research, we could say that we need trials that are controlled for the major confounding factors, and unfortunately many more. The strength of this review is that this was the first attempt to compare the quality of life scores, so the objectified subjective outcomes, and we've attempted to stratify the populations in the included publications. The limitations are that, unfortunately, no high-quality studies were involved, not even the randomized control trials was good enough, and the meta-regression as a choice of methodology was not feasible. Currently, this manuscript is right before the internal review, and our target journal is the Oral Oncology, which is one of the top 10 journals in dentistry. The third and the fourth project are currently at a very preliminary stage, so I wouldn't go into details just yet. I would like to thank you for your attention with a quote by Mark Twain: "The man with a new idea is a crank until the idea succeeds." Thank you very much.
Congratulations, Jani, to your presentation. My question is regarding to your first project. How did you specify the marker points on the face according to what? It was your decision, or you see it from the literature, or how?
These landmarks are from anthropometry. So these landmarks are found in a handbook for anthropometrical measurements, and we found the common interlandmark distances that were published in the included articles. This is why we have only 3 in the nasal region.
While people are thinking, I would like to know if there is a long-term difference if you are using only prosthetic rehabilitation and not surgical rehabilitation. What I mean, prosthetic devices might influence the deterioration of the underlying bone or might not. I'm not sure, that's why I'm asking. And doing a surgical reconstruction might prevent this. I am asking this.
Yeah, thank you for your question. Fortunately, prosthetic rehabilitation requires continuous surveillance of the prosthetic appliance, which is a burden for some of the patients because they have to get into the clinic every couple of months. But there's a good chance for us to perform another stomato-oncological examination for each and every patient. But the underlying bony tissues or the bone resorption with this surveillance is not an issue because if the patient is telling us that the stability of the obturator is not that great anymore, then we could perform a relining or a rebasing procedure right away.